This video demonstrates a modification of the MORCHER capsular tension ring, where the leading end of the capsular tension ring has a little bit more acute curvature, so that when it's introduced into the capsular bag, there is less stress on the zonules and a smoother introduction. So this is a case with a small pupil with posterior synechia, and you can see I've broken the posterior synechia with a dispersive viscoelastic, and now I'm using 2 Kuglins to stretch the pupil. I would not do this maneuver if it were a case of IFUS, as that would make the iris even floppier during the surgery. That was not the case here though, and additional viscoelastic was introduced to expand the pupil. The capsulorhexis was then performed with Utratas, and during the capsulorhexis is usually when you get the first idea that there's some instability of the zonules or weakness of the zonules in one area or even generally. And because of this instability, I made the decision to introduce a capsular tension ring, and you can see when it came out it just has a little bit more acute curvature at the tip of the CTR, and that allows for a smoother introduction with less distortion of the bag and less stress on the zonules at the opposite side from where the leading edge or leading end of the CTR is being introduced. And then an intraocular lens was implanted. So here's a second case. Again, appreciate that little bit more acute angulation or curvature of the leading end of the CTR as it's being introduced. This is the preloaded EyeJet version of the CTR, and I prefer this because it's very fast and simple to introduce it at the time that you notice the need for it during surgery. Nothing special has to be done to load an inserter with the CTR. Now here's a case of a very loose bag, and even during the irrigation aspiration it was very apparent that there was poor zonular stability that was generalized. And because the bag is so loose, it's often jumping into the irrigation aspiration port, and so care has to be taken not to engage and cause further weakness of the zonules. Once the capsular bag is inflated with viscoelastic, a traditional type 14 MORCHER CTR was attempted to be introduced, and there was significant displacement of the capsular bag. You can see how much straighter that introductory end of the CTR was. I even tried to manually create a bigger curvature by just kind of forcing a bend in the end, and there are other techniques that can be used, such as putting a suture through the end or a Sinski hook. But in this case I chose to just try to create a more acute angle at the leading end of the CTR, and it was still distorting the orientation of the capsular bag and dragging in the fornix. I then switched to the new type 15 design of the MORCHER CTR, and you can see that just that little bit of an increase in the acute angle of the curvature at the end allowed it to be inserted without displacing the capsular bag significantly. Even though I did have to hesitate a little bit here, drew it back and then inserted it, and it went around very smoothly and allowed for less trauma to the remaining zonules during insertion of the CTR.